Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Vani Velkuru. Dr. Velkuru is a board-certified rheumatologist. She received her medical degree at Sri Devaraj URS Medical College in India and completed her internship and residency at UCLA Kern Medical Center in Bakersfield, California. Dr. Velkuru practices medicine in the field of rheumatology in Fremont and is a staff member at Washington Hospital.
Good afternoon, everybody, and hope you guys have a good lunch while we talk about arthritis today. So today I'm going to briefly touch on the different types of arthritis, how to manage the same, how to look for the red flags of arthritis. Again, arthritis is a vast subject, so I'll try to cover briefly, and if you have any questions, I'll be happy to answer you at the end. So arthritis, it's a complex family of musculoskeletal disorders, and it involves more than 100 different types or different diseases that can result in joint damage and structural damage to our musculoskeletal system. What is the impact of arthritis we see in our community? So it's around, we spend around $7 million for physician visits per year, and it involves $3 million for hospitalizations per year. The average medical cost per person per year is around $2,500. About 27 million Americans are living with osteoarthritis, and osteoarthritis is the most common form of joint disease. We will talk more about the types of arthritis, and osteoarthritis I will describe more in detail. Osteoarthritis, it's the top cause of disability in our older population. The lifetime risk of developing osteoarthritis in the knee is 46% and in the hip is 25%. It's a slowly progressive joint disease which it becomes chronic or as the time progresses, and it can affect anyone. It could usually affect between middle age and elderly population, but it can affect earlier. It can have an earlier onset if there is more other predisposing factors. And it's commonly termed as osteoarthritis is commonly called as a wear and tear type of arthritis. What it is characterized by breakdown of the cartilage. Cartilage is the lining of the bones. So every joint has a lining on the bones. Two bones together form a joint. Let me show you this. I don't know if everyone can see it clearly, but you're welcome to see this at the end of the talk. So this is the joint. This is the knee joint, and you can see this white lining on top at the end of the long bones, and this is what we are talking about as cartilage. So in wear and tear arthritis, it results in breaking down of this cartilage, and it also involves bony changes in the surrounding bones near the joint. It also is involved with deterioration of the tendons and ligaments around the joint. So this is a picture On the left side, you can see how a normal joint looks. You have a smooth lining, you see a capsule, a nice smooth cartilage, and the lining of the capsule is also called synovium. And you see the bone next to the joint. On the right hand side, you see osteoarthritis or the wear and tear. You see that the capsule is thickened. You see cyst formation in the bone. The cartilage is degenerated, or it's not as smooth. I will show you more pictures as we go along. And also you can see that the bone is not smooth and there are extra bony growths which are called osteophytes. And this is we are talking about the regular wear and tear arthritis. And in inflammatory arthritis, like rheumatoid arthritis, it's a different picture. It's proliferation in the lining of the joint. This is a joint of the hand, and you can see how it progresses. Initially, a normal joint is supposed to look like the one on the left hand side. As it progresses, you see the the cartilage deterioration and the thinning of the cartilage as the disease progresses. And the extra bony growths you see at the end of the bones they are called osteophytes. This is a pathology of a cartilage. The one on the top is normal cartilage. The one below that is the cartilage in arthritis or osteoarthritis. You can see multiple number of cells. There is less matrix. This is an arthroscopic view. Arthroscopy is where you you look into the joint through a camera. And on the left hand side, you see a nice smooth lining. That's a normal joint, and this is a knee joint. On the right hand side, you see the fibrillations or the fraying of the cartilage, and that is what exactly happens in our osteoarthritis. So who gets osteoarthritis? It can affect people of all races and both sexes. Most often it occurs in patients 40 and above. But as I said, if patients have predisposing factors or are at a risk, they can develop it at any age. It can develop in children as well. The causes of arthritis, no one really knows one. It's multifactorial. So common risk factors being the age, obesity, injury or overuse of the joints, and hereditary or genetic etiology. So in older population, around 75% of people beyond 70 years have osteoarthritis. That's how common or prevalent it is. And second common risk factors, if we have a family member or parents or grandparents who have arthritis, if we share the same genetic predisposition, we could develop arthritis. It could be much earlier onset, it could be much more progressive or much more severe. Obesity, another very common factor for developing arthritis. Trauma or previous injury to the joints can predispose to it. Joint injury or repetitive or overuse of the joints can result in early onset of arthritis as well. And other joint deformities like unequal leg length, bow legs, etc. There are two types of osteoarthritis. Primary is where it is just wear and tear. Secondary is a variety where it is in conjunction with other types of arthritis like rheumatoid arthritis, gout. So there is inflammation in the joints. As a result, the joint gets damaged and subsequently develops osteoarthritis. The common sites or the common areas of involvement in osteoarthritis include hands, spine, and the other weight-bearing joints. As you see here, the hips, knees, and the great toes. So this is commonly the routine type of arthritis we see typically starts in these areas, but it can happen in any other joint. This is a picture showing arthritis involving the hands. The hands look deformed, but this is not inflammatory in nature. I will go into rheumatoid arthritis briefly. So there are two types of arthritis. One is inflammatory, and under that, rheumatoid arthritis, gout, psoriatic arthritis, all these come into. The other type, non-inflammatory arthritis, is the osteoarthritis. So here, you can see the bony deformities or the joint deformities in the hands, and this is just simple osteoarthritis. And the nodes are called Heberden's and Bouchard's nodes. This is a picture of a patient with rheumatoid arthritis. Severe rheumatoid arthritis, this is what happens if early interruption or early medical treatment is not initiated. So it can result in irreversible joint damage. So the goal is to prevent this from happening. So again, inflammatory arthritis damages the joints much quicker than the regular osteoarthritis or the wear and tear type. And you can see in that you see a few nodules, and those are called rheumatoid nodules. So rheumatoid arthritis, it's a form of inflammatory arthritis and is an autoimmune disease. So what I mean autoimmune is the immune system is actually supposed, or it's supposed to target against the foreign bodies like bacteria, viruses. It's supposed to fight against them, protect our health from it. But in rheumatoid arthritis, no one really knows the exact etiology. The immune system starts noticing the body or the joints as foreign and starts attacking the joints. So it gradually results in inflammation in the joint lining and subsequent joint swelling, damage, and deformities. I would like to show you a picture of rheumatoid arthritis. So in rheumatoid arthritis, it is a little different. So we are talking about joint lining. You can see the red lining here, and that is the inflammation. So the immune system starts attacking the lining. It's also called synovium. Once it attacks, the synovium grows, proliferates. You tend to accumulate more fluid in the joint. This results in joint pain, swelling, and resulting joint deformity. It also progresses to bony deformity as well. The bone starts getting eroded. Also in rheumatoid arthritis, the patient will be at a higher risk to develop osteoporosis or thin bones. This is another picture of the hand showing rheumatoid arthritis. You can see the lining of the joints proliferating in all the joints of the hands. And this is also called pannus, or the lining of the joints getting proliferated. So as a result, of this, we tend to develop rheumatoid joint deformities. It's very prevalent. Around 1.3 million people in the United States have rheumatoid arthritis, which is around 1% of the nation's adult population. Another common arthritis that we see is gout. This is also called crystal-induced arthritis. So the joints are the DIPs, or the distal interphalangeal joints, what it is called, shows deposition of uric acid. They are also called tophi. So you can see that, and sometimes if they don't have the whitish texture or tinge to it, it can simulate osteoarthritis. I'll show you another picture as we go along. So gout is an inflammatory arthritis. It's caused by uric acid deposition in the joints. Uric acid, they accumulate as crystals, and the joint pain comes as episodic. Typical joints involved is the base of the first toe, that's also called podagra. That's the common site that we see in gout, but not necessarily. Other joints can be involved, like ankles, knees, wrists, and the elbows. So the uric acid, it becomes episodic in nature. It's not, so once you have an attack, it will stay. It can last for a few days, few weeks. After that, it tends to get better, and then you can have a recurrent episode later. So there are some predisposing factors to gout. One is kidney or renal insufficiency or kidney problems. So that commonly seen in those patients as well, because they cannot excrete the uric acid from the system because the kidneys are not functioning well. And other type of people who tend to see or who tend to have gout are patients who produce a lot of uric acid or overproducers. So briefly on the symptoms of arthritis. When are we supposed to look for the red flags of arthritis? Most of the time the symptoms just start like joint pain, joint stiffness, and occasionally joint swelling. We see more joint swelling with inflammatory arthritis like rheumatoid arthritis and gout. In regular osteoarthritis, there can be episodes where you can have joint swelling. Again, you need to be aware you can have stiffness in the morning, but when you ask the patient how long the stiffness is, if it is just as soon as they wake up in the morning, as they start moving the hands, it tends to get better, then it's mostly the routine type of arthritis. But if they say that stiffness lasts for more than 30 minutes in the morning, or sometimes it can last a few hours, then it could be inflammatory in nature. And the other typical symptom is when after periods of inactivity, like after sitting in a car for a long time, sitting down in a chair for a long time, as soon as you stand up, you tend to have stiffness in the joints, and as you walk, it tends to get better. There are other types of arthritis which doesn't get better, it actually worsens on weight bearing or walking, and that's more seen in inflammatory arthritis as well. There is a subsect that I'm not touching today, which is arthritis involving the spine, which is diseases like ankylosing spondylitis and other arthritis that cause inflammation in the spine. They have morning stiffness involving the back, and that lasts, it's very severe. It tends to get better with activity, and after periods of inactivity, they tend to have a lot of lower back stiffness. So if you have a joint swelling with erythema or very tender joint, very warm to touch, then it's better to seek medical help to figure out what type of arthritis it is. Other symptoms of arthritis are swelling, knobby swelling at the joints, and I've shown you a picture. The rheumatoid nodules can look like that, tophi can look like that, or just simple osteoarthritis can look like that. Symptoms like cracking or crepitus when you move the joint, it's that crunchy noise it makes. That could be a symptom, that could be an associated symptom of both inflammatory or non-inflammatory arthritis. And most of the type of arthritis are involved with decreased function of the joint. This is again a Hibberdon's node. It is associated with, so patient goes to bed overnight, you have swelling, so patient gets worried. But this happens in some types of osteoarthritis. To few days it stays like that, and then it tends to get better. But it can result in nodes called the Hibberdon's nodes that I showed you before. So how do we diagnose what type of arthritis it is? Number one, getting a proper history and doing a physical examination, seeing what type of swelling is it, is there any fluid inside the joint, is it warm to touch, is there any loss of activity, we check for the range of motion. So very important is history, how it presents, is it every day, has it been slowly progressive, or is it episodic in nature. Second thing that helps us diagnose is lab tests. Lab tests like rheumatoid factor. There are tests, specific tests to diagnose rheumatoid arthritis. You do uric acid level to diagnose gout. There are other genetic testing that can be done for arthritis involving the back. So blood tests and in inflammatory arthritis, inflammatory markers are elevated. So they do help us to make the right diagnosis. Last but not least, imaging, X-rays of the joints. How do the joints look? Do we see any erosions? I will show you a couple of pictures. The way a joint looks is different in different types. In regular osteoarthritis, in the knees, for example, you just see one compartment narrowing or medial compartment narrowing. In rheumatoid arthritis, if the knee is involved, you see the entire joint being narrowed down, and that is as a result of the inflammation. And in psoriatic arthritis, there could be bone resorption. The bone starts getting eroded, and that is it's called pencil and cup deformity. But I won't go into the details. So each type of arthritis, they have characteristic features which help us to diagnose. So this is just brief. This is how an X-ray looks, and this is just osteoarthritis, routine arthritis, but you still see the joint deformity resulting from this. This is another closer picture of osteoarthritis. You see, when I say proximal and distal joints, I'm referring to the distal joints up there, and the proximal ones is the one below that. So typically in osteoarthritis, you can have distal or these joints are involved. In rheumatoid arthritis, majority of the time, the distal joints doesn't get involved. It's usually the metacarpophalangeal or the MCP joints, what they are called, and the PIP joints. So each disease has a particular joint predilection. This is another picture of erosive osteoarthritis. Here, you see that the bone is eroded, but still this is the non-inflammatory or the regular osteoarthritis. This is a picture of severe rheumatoid arthritis. You see that the bones are thin right next to the joint, and this is called osteopenia. So this patient is at a much higher risk to develop osteoporosis or thin bones. This picture or under C, you can see the bone is not smooth. You can see the bony erosion there. And this is again a picture of the wrist in severe rheumatoid arthritis. And that's why we worry if patients who have rheumatoid arthritis, they don't get appropriately treated. It can result in severe deformity. And once you come to a particular or advanced stage, it's hard to reverse what has happened. So earlier on, if you control the inflammation, this can prevent from happening. This is the arthritis involving the knees. There are different compartments. There are 3 major compartments in the knees, and you can see that the bones are touching each other. So the cartilage is complete. What happens in osteoarthritis is the cartilage gets worn off and the bones start rubbing against each other. One of the reasons why we have pain when you start moving the joints. This is arthritis involving the hip joints. On the right hand side, you can see a joint space, but on the left hand side, you don't see a joint space in the hip. And this is a patient with rheumatoid arthritis. And this type of hip involvement can also be seen in ankylosing spondylitis and other arthritis involving the back, including psoriatic arthritis. So let's talk briefly on the management or how to take care of the arthritis. Prevention is better than cure. So modalities to prevent is weight loss. Number 1, weight loss. Obesity is the single most important modifiable risk factor. So if you excess weight not only puts pressure or excess load on the joints like the knees, hips, etc., it also causes a systemic, it releases some obesity or adipose tissue releases some chemicals, so that tends to damage the joints. It also has systemic effects. So for every pound we gain, we tend to add 4 pounds of pressure on the knees and 6 pounds of pressure on the hips. So weight loss definitely helps. Even if it is modest. So there is a saying, if you lose 10 pounds of weight, you can reduce the risk by developing arthritis by around 25%. Second modality is exercise. So there are various types of exercise, and the main goal to exercise is to improve the muscle strength and function, and to improve the joint function. It also decreases the joint pain if in case the patient already has arthritis. It decreases the pain and stiffness associated with it. Also, it lowers the chance of disability secondary to the arthritis. And exercising is fun. Stretching, there are various types of exercises. Number one, stretching exercises. Yoga, Tai Chi, all of those are stretching exercises. They tend to improve our flexibility and tend to improve our muscle strength. Aerobic exercises, and those could be fitness walking, it could be water aerobics or pool programs. Because when it comes to exercising in water, the water offers some buoyancy around the joints, so it prevents jerky motions to the joints, and patients can tolerate exercising in water better, especially who have moderate to severe arthritis. Earlier on in so you can modalities like walking, regular walking, or cycling in a stationary bicycle, all those are good. It doesn't put too much impact on the joints, especially the lower joints in the lower leg. But what if patients are not able to exercise because of the pain? Something to consider would be water aerobics, where you can do the exercises in water, and so because of the buoyancy of the water, it's hard to move the joints quickly, and in turn actually reduces the joint pain associated with exercise. The other type is strengthening exercises. We do strengthening exercises in order to build strength and endurance in the muscles around the affected joints. When the muscles around a joint weaken, the joint tends not to function properly. You tend to see more arthritis in joints which don't have good muscle support. So if there is any trauma or any predisposing factors that's damaging the surrounding structures, you will tend to develop osteoarthritis much earlier on. So these are prevention modalities, and to some extent they cover the non-pharmacological modalities to treat arthritis. Let's come to the pharmacological interventions. And also in addition to the ones which spoke about, joint protection with bracing or using walkers, canes, etc. to give some added support to the joints. It's okay. It would be beneficial, especially if it is severe arthritis. And bracing, especially to unload the pressure on the joints, it depends on the type or the stage of the arthritis that the patient has. So the goal of treatment, including medications, is to reduce the pain and to improve the function. If you don't use a joint, you tend to lose the motility associated with it. So many patients ask, should we walk? We are having a lot of knee pain. Should we walk? Yes, you should. But don't overexert, but I would definitely continue exercising. You don't have to do anything that stresses your joints like jogging or like any overexertion. But regular brisk walking is good, not only for your joints, but your overall well-being as well. And also, why we use medicines is, as I mentioned, is to prevent the joint losing joint function and in turn disability. Treatment again varies based on the type of arthritis. So, it's in inflammatory arthritis. Inflammatory arthritis, I will show you a slide shortly. There are medications which has to suppress the immune system. So in rheumatoid arthritis, the immune system is attacking the joints. we will have to use medications that suppress the immune system from attacking the joints, and which means the overall immunity will be suppressed. But when you take the risks versus the benefits of such treatment, the benefits outweigh the risks. So there are medications like, let me go to that slide and then come back. Okay, these are the ones I'm talking about, and these are mainly used in rheumatoid arthritis and other inflammatory arthritis. So they are disease modifying anti-rheumatic agents. So these are the ones that suppress the immune system from attacking the joints. The other medications you would have commonly heard is biologics. I don't know if we can use like brand names here, but Humira, Enbrel, these kind of TV advertisements everyone would have seen. So all of them belong to biologics. Those are all injectable medications that they are potent, and again it always has to be under supervision because they are associated with risks like suppressing the immune system, and there is a possibility of adverse effects. So this modality is mainly followed in rheumatoid arthritis or inflammatory arthritis. Today I'm just going to concentrate on treatment of osteoarthritis. So treatment mainly is topical agents, oral medications and injections. Topical agents, these are mainly applied directly to the skin over the affected joints. They come in various varieties. There could be creams, gels, patches, rubs, sprays. Most of them are over the counter. Some of them are prescription only. So they belong to various categories like salicylates. Some of them improve the blood flow to the area. Some of them irritate the skin. They are called irritants like capsaicin. It's made from chili peppers, and it actually irritates the nerve endings, and it's supposed to distract the pain. There are other medications which suppress the substance P or the transmission of pain. So there are various varieties that could be used topically and as needed. The possibility of side effects is a little less compared to taking orally, because when we apply a medication topically, not everything is absorbed. It's only to some extent it can be absorbed. So they are relatively safe compared to the oral medications. Topical pain relievers like capsaicin or diclofenac, don't use concomitantly with heat therapy, or don't use heat pads or bandages on top of it after you apply them. Other modalities, some patients ask, which is better? Should I apply heat? Should I apply cold? Which is better for me? Depends on the patient. Some patients feel better with heat therapy. Some patients do better with cold. So there is nothing that one modality is better than the other. You can use either heat or cold packs. And heating also involves paraffin wax treatment, especially used for arthritis of the hands and the feet. So these it involves the paraffin provides some heat treatment, or it gives heat to the joints, the smaller joints, and in turn it relieves the symptoms. Coming to the oral medications, again the goal is to reduce the swelling and the pain. Commonly used medication for most of the arthritis is acetaminophen, what we commonly call as Tylenol, which is a brand name. So acetaminophen works good. It doesn't interfere with too many medications. But if patient starts using it more than 4 grams per day, then it is associated with liver toxicity. But as a medication, since it does not cause gastrointestinal or stomach irritation, it is better tolerated. And in arthritis, we tend to take the medication regularly. So if acetaminophen helps, then I would stick to it, or that is the first treatment that is that is safer compared to the other modalities. Other medications or NSAIDs or non-steroidal anti-inflammatory drugs. Under this comes the Aleve or ibuprofen, naproxen, diclofenac, all these over-the-counter and prescription medications. So these are anti-inflammatory. They do decrease joint pain, inflammation in most of the types of arthritis. But you need to be careful when you use these medications in case, especially if you have stomach issues. It could be gastrointestinal bleeding, it could be stomach ulcers. If you have a history of that, be very careful when you use these medications, especially when you use them on dosages beyond what is prescribed. So the other in patients who have heart problems, who have stroke, kidney or renal problems, and stomach ulcers, as we spoke about, I would talk to your doctor before you use these medications. And also high blood pressure, uncontrolled high blood pressure. So even though they are available over the counter, I would still talk to the doctor before you start or use these medications, especially if it is on a routine basis. Not here and there, but some patients use it every day. So it's better to discuss about the same. Coming to joint injections. So joint injections, there are mainly two types. One is injecting steroids or corticosteroids. And I think going back, on the rheumatoid arthritis as well, oral steroids are used, oral corticosteroids. The reason is steroids suppress inflammation. So when you take it orally, it benefits conditions like rheumatoid arthritis. But in osteoarthritis, where there is joint pain or it's local, injectable steroids are preferred. So the steroid is injected into the joint, and you cannot do it into the same joint for more frequently than 3 months, or you should limit it to 3 to 4 times per year. Some patients do it for knee pain. They can do it, but we should not use it we should not do it frequently than 3 months. The steroid injection can, they can provide relief. The main goal or reason is patients can move better and exercise better. So some patients, they don't like doing the shots, but once they get it and it's painful or it's more anxious actually to get a shot into the joint, but it tends to help in some particular types of inflammatory arthritis. The other types of joint injections are hyaluronic acid, or what we have commonly seen as Hyalgan, Synvisc. These are hyaluronic acid derivatives. These are typically used for knee arthritis. They are injected into the knees, and this provides, so our joint has a substance called hyaluronan. As the joint develops or gets older or worn and wear and tear sets in, the amount of hyaluronan decreases. So what we are trying to do is replace that or inject hyaluronic acid into the joint to provide a cushioning benefit for the patients. This is especially used once the patient fails steroid injections into the knees. Many patients ask me, so they are actually initially derived from rooster comb. So the combs of the roosters, that's where the material is actually derived. Other complementary remedies, people talk about herbal remedies, taking chondroitin or glucosamine. All those research has not proven completely, and that's the reason we don't prescribe them. But if the patient says, I take chondroitin, I take glucosamine, I feel better, that's fine, you can take it. But research hasn't completely proven that they are very beneficial. And other modalities like acupuncture, etc., it causes temporary relief. So if patient feels has symptomatic benefit from it, you can proceed with that. Last resort, if everything fails for refractory joint pain, is when surgery comes in. We try to postpone surgery as much as we can because each joint, after it is replaced, has a lifespan. So even that is involved, we can develop wear and tear, not exactly wear and tear. There is a lifetime or so many years that the joint, the prosthesis will be good. So we try to postpone it, and the modalities we spoke about, medications, injections, etc., even though they don't reverse the osteoarthritis, they can help symptomatically and to prevent or postpone the surgery. So if nothing helps, all the modalities we talked about, nothing helps, patient is in a lot of pain, not able to exercise, quality of life is being interrupted, regular activities of daily living is becoming a problem, that's when typically we refer the patients for surgery. So surgery, again, there are types. Arthroscopy, where you just go in with a video you just make a small incision, look into the joint, just fix the torn ligament or meniscus. The second variety is a total joint replacement. So there are various modalities in surgical interventions. There is a lot of research going on in arthritis. There are more number of medications. In the last 10 to 15 years, there is tremendous number of medications that came out, especially for inflammatory arthritis. But unfortunately for osteoarthritis or the wear and tear arthritis, there is no medication that can prevent the progression or can reverse the joint damage. So, this is the common type of arthritis. So prevention is actually better because once it sets in, there is nothing that can really stop it from progressing. But everyone's hoping for a miracle drug that the research will come up with to prevent or help with the same. So I have briefed basically on the types of arthritis, what to look for, what are the treatment options. I hope you enjoyed the talk. Thank you. Thank you.